access to a lot of his experience. Life goal of mine is to get half of the experience that he's been able to accomplish. Dr. Kevin Young completed his internship and postdoctoral fellowship at IOL in Hartford Hospital. He's currently the manager of psychological testing and directs the neuropsychology fellowship at the Institute of Living, where he's also the assistant director of psychology training. He and the neuropsychology team at the IOL designed the neuropsychological assessment portions of Hartford Healthcare's late career assessment service that is now entering its third year and will be the topic of discussion today. We're really, really excited to hear you speak, and I can tell you firsthand there has been a lot of interest and excitement to hear you today. So thank you for being here.
Great, thanks for the introduction. And like all these talks, I'm hoping that at the end, we'll have lots of time to go over questions. When I presented this before, folks have a lot of interest in specific questions, so we'll be recording those. And please feel free. It's better if it's interactive in a way. Here are the disclosures. I have no disclosures. There's no support for this activity. The moment of getting your text code. And Erica, I broke a rule. I'm going to leave that text code up in a sneaky way on the next couple slides.
I'm okay with that. People will appreciate it.
Sure. So the objectives today are we're going to identify for all the folks who are attending to be able first to identify the frequency of impairment in late career physicians and late career providers for the purpose of this talk. At HHC, this process involves any doctors, psychiatrists, dentists, podiatrists, and advanced prescribers. Attendees are going to be able to identify barriers to the identification of impaired physicians. And so why do we need a process? We are going to be discussing what is the unique difficulty in implementing an age-based performance evaluation requirement, and there are several difficulties. We're going to talk about the why you need a specialized assessment for physicians and providers. And I'll be talking about some of the complexities, so the complex interpersonal dynamics that a process like this brings up, as well as difficulties with boundaries that come up in these evaluations. The first thing to do, though, is to credit the folks who helped develop this process and who implement it. So in neuropsychology, this is a group of folks who either helped with designing the assessment battery or are everyday testing the physicians from Hartford Healthcare. At IOL, there was a group of folks who were instrumental, and again, I apologize if I forget anyone, but who were instrumental in getting this program started and getting our team involved. At HHC and at HH, there's a group of folks that we work with on all these evaluations. So whenever we're testing folks at HH, Dr. Steinberg, Attorney Hurl, but also Dr. Kumar, Orlando Robinson. We're involved with them constantly on these cases, and they've been really helpful. I've learned a lot from them. The CVO and MSO folks are the ones managing this for the system. And then in psychology, poor Paula has to call and schedule. This got added to her workload. So she is calling and scheduling all of these evaluations, and that actually brings its own difficulty, which I'll mention later on. So I guess the first thing to mention is just to talk about physician retirement trends. Since 1975, there's been a massive increase in practicing physicians over age 75. So almost a 400% increase in the physicians that are practicing after age 65. In 2015, 23% of physicians in the U.S. were over 65. About 20,000 physicians each year age into that category over 65. And there's about, just on the other side, there's about 20,000 new physicians annually. Per the CDC, somewhere between 10 and 20 million hospitalizations and 50 to 70 million office visits are managed by physicians over age 56. And you have to pay thousands of dollars to find out over age 65, so I don't have that, but it's a large number. In 2019, about 420,000 physicians were age 55 plus. And the Association of American Medical Colleges extrapolated forward that greater than 40% of physicians will be 65 or older within 10 years. So we have an aging workforce, and folks are working later in their career. And because of that, AMA has called for guidelines for competency testing for the aging physician. They've asked that there's 3 parts of competency that we look at: mental and physical health, cognitive performance, and then the standard reviews of clinical care. examining cognitive performance is novel, and it's different from the ways that we've traditionally looked at physician competence. This is how the DSM looks at different domains of cognition, and it's not quite the way that folks in neuropsych would look at the ways of cognition and how they break down. But just to really briefly socialize this to the audience, we're going to be thinking about visual functioning, visual spatial functioning, motor functioning, language, and communication skills, learning and memory, which is going to involve your new learning and your acquisition of new information, as well as your recall for things you've learned in the past, skill sets, and information that you know. Executive functioning becomes really important in these evaluations, and executive functioning is this kind of umbrella term, but for the purposes of this talk, really the cognitive aspects of executive functioning, planning, decision-making, your working memory, your ability to respond to feedback in novel situations, so your reasoning, inhibition, cognitive flexibility, being able to see that something's going wrong and changing your approach all become really important. Complex attention, which the DSM lumps processing speed into complex attention. So, what can you handle? How much can you handle at once and be aware of and process and utilize? And then social cognition is another domain that the DSM examines as part of neurocognition. For when you're talking about the practice of medicine and you're talking about provider assessment, the first thing we really have to think about is, what do you need to practice medicine well? I think all of our late career practitioners, but everyone else too, would really talk about crystallized knowledge. You need to have facts. You need factual data. You need to know about the practice of medicine. You need to know about disease types. You need to know about your differential. You need to know what the current tools and techniques are, and you need to be familiar with those and able to use them. Another really critical aspect, and this is something that comes up more in our evaluations, is fluid intelligence. So your ability to reason and processing. So for example, attention, being able to stay with a patient as they're giving you a clinical history and hear the whole patient's story. Your working memory, which is going to be critical in creating a comprehensive case formulation. Executive functioning, reasoning and problem solving, again, judgment, mental flexibility, self-awareness and self-monitoring, and emotional control and inhibition. All are critical parts of working with patients. Learning and memory, so are we actually remembering what we are learning from our CMEs, and are we remembering what's happening in our day-to-day evaluations? Language, the ability to communicate effectively with your patients, the ability to communicate effectively with peers becomes really important. And of course, visual, spatial, motor, especially for those who are who are involved in procedures, surgeries, things like that, become critical elements of their cognitive profile. One thing that I'll mention, and that will become kind of an ongoing theme in this talk, is that depending on what a provider's skill set is, what their specialty is, all of these areas of cognition will have a different level of importance. So, for example, in psychiatry, having a motor impairment probably doesn't impact your functioning very much at all, but having a language impairment really would. Okay. So just first a background on what happened, on something that's going on for all of us right now and its impact. And so it's important to review that there is normal and usual aging. So we are all aging, and there are changes that come with aging. So as we age, our color discrimination declines, our hearing, visual acuity, and depth perception all decline as well. Just part of normal aging. It's not pathological. It's just what happens as we age. There's a decrease in fluid intelligence as we age. So we do slow down a bit as we get older. Again, not pathological, not a dementia process. Everyone speed decreases as we age. That means that your reasoning, your processing, your ability to process information rapidly, your problem solving, all decline with age. There's also good things that happen with aging. So an increase in crystallized intelligence. So the knowledge, the facts, the skills, the things you've acquired over your life, the stuff that you know, that all increases over time. And you have to look at the relationship of both of those things to figure out the impact on an individual and their functioning. Generally, adults in their 60s are about 2 times slower than adults in their 20s. Mean cognitive ability declines about 20% from age 40 to age 75. But this is for the general population. And then the question arises, what about doctors? What about providers? What about these extremely smart people? And that's where the issue of cognitive reserve comes into play. Cognitive reserve is a really important concept. And there's brain reserve and there's cognitive reserve. In essence, what the theory of cognitive reserve states is that those who are better educated with better nutrition, more social stimulation, more engaged cognitively. And if you think of the work of a provider, you're in a hospital, you're constantly engaged, you're constantly thinking, their brain's going to function better and it's going to be less susceptible to insults. On the contrary, on the other side, folks who are malnourished, who are not well educated, who are lonely, who are sitting home watching TV all day, that's going to result in lower cognitive reserve. The difference between brain reserve and cognitive reserve probably isn't all that important for this talk, but the argument is that there are folks who have increased brain size, synaptic density, and just basically the meat of the brain is in better condition. And folks who have that better condition of the substance of the brain are going to be more resistant to change and insult as well. I'll come back to cognitive reserve and why it's really a critical thing to think about when you're assessing really, really smart people. Going back to, so we talked about normal aging a little bit, and when you're using the different terms to define these things, usual and normal aging are changes in cognition that are not different from other healthy individuals of the same age. So as we age, again, there's going to be changes in our cognition, and there's going to be a certain amount of change that is expected and is normal, and then there's a certain amount of change that there's a threshold where you go beyond that point. We don't know exactly what the impact of normal aging is on the practice of medicine, and even less so what normal aging does in any specific specialty. Then you go into the disorders of aging. So mild cognitive impairment is, in essence, a change in cognition that exceeds expectations. It's not normal, it's not usual, but without a discernible functional loss. The problem with the diagnosis of mild cognitive impairment is functional loss can look very different in someone who's functioning as a physician and someone who's functioning in a different area. And so for someone who maybe has a lower baseline functioning, the functional loss may be in the ability to tend to their basic IADLs, tending to their basic shopping or using the phone or things like that. But folks who are functioning really, really well at baseline, it's unclear exactly where that line is. Mild cognitive impairment is generally considered a transitional state between normal aging and dementia, but not all folks progress, and some causes of mild cognitive impairment are reversible. Over age 65, about 10 to 20%, depending on the populations you look at, meet criteria for mild cognitive impairment. And again, changes in cognition that are beyond what you expect, but there's no real evident functional loss. And there's different types of mild cognitive impairment. Some folks have a more amnestic presentation. Memory is really uniquely what has declined. Other folks, it's non-amnestic. It's not just memory. It might be other domains or multiple domains that have been impacted. The etiology of mild cognitive impairment can be important in treatment planning and work implications. But then again, as I mentioned, this leads to these questions. Does MCI present the same in doctors? So when you take folks who have really, really high cognitive reserve and they start to decline, there's probably going to be a degree of decline that may start to impact their ability to work, but it has not yet impacted other areas of functioning. And that's this really dicey, not well researched thing that we're trying to understand when we're creating a process like this. To the second question, does the practice of medicine require a higher level of functioning than other daily living skills? I think we would all argue yes. And so this is where this gets confusing. Other just definitions to share with the group. So, and I know this is really familiar, I'll go through it quickly for this group, but mild versus a major neurocognitive disorder. A major neurocognitive disorder is AKA dementia. Alzheimer's disease becomes more prevalent as you age. Over age 80, about 50% of folks have Alzheimer's disease. There's multiple subtypes. Vascular dementia, your cardiovascular diseases cause changes largely to blood flow. That's going to change nourishment to that eventually gets into the brain, and that's going to cause changes in your cognition. This is actually, I've started because it's the most common thing that we see during these evaluations, are suggestions of vascular-related cognitive change. FTD, is something that occurs a bit younger, so between 45 and 65, where you have real changes in frontal and executive functioning, and the most concerning for psychiatry is probably FTD. This is probably something that we would, when you think about the skill set needed for psychiatry, if you're thinking a little bit slower when you're with a patient, that's probably not going to be a big deal. When you start forgetting things, more of a deal. But when you don't have good judgment and control, it's going to be a much larger deal, in theory. Lewy body and Parkinson-related dementias are other ones that are really common. There are reversible causes of cognitive change. So psychiatric functioning, when people are really depressed or have other psychiatric illness, is going to change their cognitive abilities, at least temporarily. There can be medication side effects. And as folks know who work in Gero, as you get older, folks are more sensitive to medications and can have more deleterious effects at otherwise normal doses. Vitamin and nutrient deficiencies are also things that can change cognition. And those are all reversible. Ideally, if we do identify something, we find something reversible. That's one of the goals of this process. So again, just expected age-related changes. Age does impact the brain. After about your mid-40s, we lose about 2% of our white matter annually, and there's also going to be volume loss that continues. So folks who are at least in their 40s, we're losing that white matter, and that's probably why we're slowing down a little bit over time. It's just part of aging. There's nothing, unique or there's nothing pathological about it. White matter disease increases, and your lesion burden is going to increase over time. Your neurons, your dendritic spines are going to decrease in size and number, and you're going to have an increase in inflammatory proteins over time. Again, this is age-related expected changes in your brain. This is that theme I said that's going to keep coming up, the impact on competence. It's going to really be contingent on specialty. So I'm not going to go through all of these, and this is something that is why we need a team. When we have findings on our providers, a team of folks meets. The neuropsychologist meets with the VPMA, the chief, the head of the medical staff, and we talk, someone from legal, usually Jackie, we talk about these cases and say, okay, for this provider with this set of responsibilities, what does it mean that they have decreased reaction time? What does it mean that their processing speed or working memory has decreased? What does it mean that there's a change in fine motor skills and dexterity? And what can be done to help them continue to function at their best to the level that they'd like to be functioning at in a way that promotes both their safety and the safety of patients? If someone is learning slower, especially as situations become more complex, what does that mean for their functioning? When I should have mentioned, when folks hear the topic of this talk, oftentimes they think that this is going to be a talk about why we should mandate retirement as folks age. And that is the exact opposite of the goal of this program. I'll talk about that more. What we really are looking for is if we find a deficit, if we find a weakness, what can we do to help the provider function optimally and work as long as they'd like to? So the take-home message here is that crystallized knowledge doesn't change much in normal aging, and over time you're increasing the knowledge base that you have, but fluid abilities certainly do decline progressively and accelerates in your 60s. Competence can change due to normal aging as well as due to diseases of aging, and so that's really what we have to think about. When you think about the effects of cognitive change on fitness for duty, just another way to visualize this, over time, we're losing our strength, we're losing our perceptual abilities, we're losing our dexterity, and we have declines in many areas of cognition, but that's balanced by knowledge and experience and wisdom. And this is something that when I've done feedbacks with providers, because we do feedbacks with anyone who wants it, if there's been findings, some folks have said, it might be true. I don't quite think as quickly as I used to, but I have seen these cases before. I understand these cases in a way my more junior colleagues don't, and that gives me an advantage. And that's probably really true for a lot of different specialties and a lot of different areas. So again, thinking about when competence issues may surface for a provider, specialties that require analytic thinking, specialties that deal with novel, complex, and confounded presentations. So if you are in a rapidly changing, in the emergency room, perhaps, that's going to be challenging as you start to think a bit slower or as some of these cognitive changes set in. when motor changes affect interventions. If someone has a tremendous decline in strength or dexterity and they're holding a scalpel, that's obviously going to be an issue that we have to think about. When speed matters, when new technology is introduced. So this is when Hartford Hospital introduced a couple of years ago robotic cardiac heart surgery devices. Folks had to learn that. The other place that you see is when folks have to learn an electronic medical record. You can get a lot of difficulty learning the medical record over time, and that might be a cue that there's a competence issue. That's got to be balanced with non-cognitive causes of change in clinical skill. And non-cognitive causes of change can occur across the age span, including our more senior colleagues. So the clinical volume, as we're asked to do more and more, it becomes harder and harder to stay and to function at your best. Burnout is something that's got Dr. Ferrand, others talk a lot about this and the importance of burnout and how, as folks are burned out, you're not going to function as well as you would if you were at your best. Psychiatric symptoms, health issues, life stressors, changes in standards of practice, having an EHR that you have to learn, having non-clinical burdens mixed in with your normal clinical routine, pressures to practice out of scope, substance use. And of course, all of these you see all of these as part of the global pandemic, which only makes this harder. But, all these things exist outside of a pandemic as well. And all these things can be causes of change in your outcome for your patients and your functioning day-to-day clinically. Now, this is a question that if we were live, I would love to have folks answer. But what is needed to be a competent psychiatrist? Since the psychiatry grand rounds, I'm thinking about psychiatrists. To answer that question, I'm not going to answer it, but just what I would think about is there's a relationship between your knowledge, your wisdom, and your experience, and what that does for you in your setting with your patient. And that's balanced against how quickly you're thinking, your working memory, your judgment, and your reasoning. What is the relative potential for harm at different stages of a specific decline? So for someone who is having new onset of naming difficulties, is that likely to cause harm for their patients? Is that different than someone who's having subtle forgetfulness, but maybe is taking notes? Is that different than someone who's got judgment, is having judgment difficulty? And when you balance it against, if I'm doing a homicide risk assessment, but I've done thousands of these in my career, how do changes in cognition really impact? This is something that we have to think about. And it can be different for every provider depending on what they're doing. So we think about decision-making, the common factors. So someone with Alzheimer's disease, someone with a frontal temporal dementia, they may have a personality change, and that might impact how they interact with their patients. For those in administrative roles, you might be able to have a significant tolerance for speed or working memory changes because they may have assistants helping them, or they may have more ability to do things where they're not as time sensitive. Prescription decisions. I'm not a psychiatrist. I would assume that after you've been practicing psychiatry, I could be wrong, but for 40 or 50 years, some of your decisions may be kind of automatic. And they may be something that really isn't, your decisions aren't going to change much at early stages of cognitive change. So generally, the question you can ask the question, is age related to clinical outcomes? And this is a really critical question to ask because gets to the heart of should we be having a practice or not? Chowdhury and colleagues did a review of studies from 1966 to 2004. And at least more than 50% of the studies found that increasing years of practice related to decreased performance in the practice of medicine. There were declines in cognitive performance that were linked to physician performance in several other studies. This was a study of doctors and dentists who had, there was a review of folks who had suspected concerns, and there were performance concerns there. Younger doctors this is a study in Italy. Younger doctors in that study were using newer techniques and had better outcomes than their older colleagues. A lot of the data, a lot of the research on physician performance has come from surgery. They've really looked at this. There's increased mortality rates for older physicians in surgery for these sorts of procedures. In anesthesia specifically, there's increased litigation and severity of injury when providers are over age 65. Internal medicine doctors, this was a study where they reviewed what sort of care folks were getting for diabetes, and they correlated to performance on standardized tests that physicians take, every few years as they maintain their certification. Folks who did worse on those tests also provided worse diabetes care, and that was tied to age. Also, there's evidence that shows that the longer you're in practice, the less likely you are to be using current screening and other current techniques. A lot of the surgical literature suggests that after folks are after they've graduated and they're about 20 years out, they're much less likely to be using the most modern techniques. For psychiatry, though, this is completely unknown. I search and search and search, and the search terms psychiatry, competence, psychiatrist, lack of competence, it just comes to psychiatrists opining and other folks' competence. It never looks at psychiatrists themselves. So we don't have any data on this for psychiatrists that I've been able to find. There's guidance from professional organizations, which is really important to think about. AMA has said that part of a physician's professional duty is to continually assess his or her own physical and mental health and to report all instances of significantly impaired or incompetent colleagues to hospital, clinic, or other relevant authorities. I'm going to sit on that for a second and just let folks think. So folks who fit into this group, physicians, have you ever been aware of a significantly impaired or incompetent colleague? And if so, have you reported them? Because you have a responsibility to do so. AMA's Council on Medical Education. Physicians should be allowed to remain in practice as long as patient safety is not endangered. And indeed, if needed, remediation should be supportive, ongoing, and proactive. This can counter the qualms folks have about it. So if you report folks, you're not saying you shouldn't work anymore. You're saying, I have a concern. I want you to be safe. I want your patients to be safe. And maybe let's get some support for you. This is a really interesting take. Self-regulation is an important aspect of medical professionalism, and helping colleagues recognize their declining skill is an important part of self-regulation. So the AMA Council on Medical Education is suggesting that we all have a responsibility in making our colleagues aware of any changes they may be facing and helping with self-regulation, so helping with insight in order to allow folks to regulate. The American College of Surgeons has said that has recommended voluntary and confidential baseline physical and visual testing between 65 and 70, and they've put online tools available that's voluntary to assess neurocognitive functioning. And then in theory, the surgeons would then talk to someone about their results if they had concerns. Okay, the next section, I'm going to talk about self-regulation versus peer identification. It maps nicely onto our leadership behaviors. And so something that we talk about in this group of late career practitioners is, when is the right time to retire? I thought this was a really nice quote. Once surgeons have lived a life in surgery and reach a certain age, it can be difficult to humbly accept retirement. The best surgeons know when to leave the operating room for good. It's always better to do so 1 year too early than 1 year too late. It's better to be asked why rather than when. This is something we've talked about sometimes in feedback with folks who had some changes. Generally providers don't want to retire too late. You don't want to retire after something untoward has happened or after harm has happened. The question of when to retire is deeply personal. Being a physician is someone's professional identity, and it is often a key part of who they are as a human. It has incredible meaning to providers. Folks are, there's income issues. There's safety issues for self and others. There may be different thresholds for tolerance and risk depending on your profession and what exactly you're doing. So someone who's segued to a career to teaching and supervision is going to have a different level of risk associated with their practice than someone who's doing procedures every day. And that all has to be balanced in the decision making. Okay, these are some cool studies related to self-regulation. So in order to self-regulate, you have to be able to have an accurate assessment of one's own ability, skill, and be aware of decline. So the CCRASS study, that's the Cognitive Changes Among Senior Surgeons study. This was in 2008. Bielaskis and colleagues looked at 359 surgeons who went to their conference, and they gave them a computerized assessment of cognition. They also asked them to rate what would it be that would help you determine when the time is to retire. Well, the physicians in this study, the surgeons, said that their self-perceived cognitive decline would impact their decision to retire. So when I think I'm declining, I'm going to retire. But when they asked that folks who thought that they had a decline and then looked at who had a measured decline, there wasn't a correlation. So the perception of a decline in cognition didn't map on to a measured decline in cognition. So they followed up the next year. Lee et al. Followed up with 995 senior surgeons at the conference. 58% said they would base their retirement on their self-assessed skill level. But again, measured cognitive decline didn't correlate with perception. So what that suggests is that folks are going to self-regulate based on their own experience of how they're doing and if they've had a decline, but their experience is inaccurate a large percentage of the time. This is consistent with Davis's JAMA review in 2006 that looked at a whole bunch of studies over the years. It was a review of the literature and found two major findings. Physicians are poor self-evaluators. Physicians were really inaccurate when they were evaluating their own performance and cognition. And the least skilled physicians reported the most confidence in their abilities. The folks who had the most decline, had the most patient events, they were the ones who were most confident in their abilities to practice. The reason I bring this up is that this really ties into the ability to self-regulate. Davis et al. Said that we should have an external assessment to compensate for this. One of the external mechanisms is peer regulation. And per the American College of Surgeons, again, we have to help colleagues recognize their declining skills. There was a Medscape survey in 2016. 7,500 physicians said they would report an impaired peer, but that also means that 22% didn't say that they would. They would not report an impaired peer. Roches looked at this in 2010. They had about 2,000 U.S. physicians. 17% had direct personal knowledge of an impaired colleague, and about a third did not report that colleague. The reasons that they didn't report were fear of retribution, believing nothing would happen, thinking they would be punished, thinking that there would be punishment for their colleague, and hoping that someone else would do it, so bystander effect. I mentioned cognitive reserve earlier. One of the problems with being really smart, put providers up on this line. If you're at baseline really smart, by the time your decline, as your neuropathology increases, you have some time until you actually start to experience it. But if you look at the slope of folks with high reserve and folks with low reserve, by the time you're able to detect that there's a change, there's a risk for a more significant decline, a more rapid decline, which would then increase risks to patients. So cognitive reserve, while it protects against decline and it extends the life of functioning of an individual, in a way, from a work standpoint, if someone does have a neurodegenerative process, and again, you can have a change in cognition without it being neurodegenerative, without it being rapid, but if there is something going on, by the time it's detectable, you may have a more rapid course than folks who had lower reserve to begin with. The reason I bring that up is that the cadence of our assessments has been a real topic for the medical staff. And, the science would suggest that, you want to test folks, especially in these risk groups, maybe annually or, fairly regularly. But that's not necessarily going to be what we ended up doing. So as far as creating an assessment process, it takes time. You can rely on current procedures. You can mandate retirement. You could have standard kind of FPPE or observation and skill checks, or you could create a new assessment process. This is a fireman who's 104 in Bridgeport. I like that side. So mandated retirement is used for executives. He wasn't working for a while. This is used for executives in certain occupations. It's contingent on the law. Physical causes are primary for some mandated retirement. Federal firefighters, federal law enforcement, FBI have ages of retirement that are mandated. Cognition is probably the reason why they mandate retirement in other occupations. So air traffic controllers at 56, pilots at 65, judges at 70. But mandated retirement for doctors, it would be a really horrible idea. I think a lot of us would probably agree with that. You lose capable and competent providers We already have a physician shortage that we think is going to be over 100,000 likely in the next 10 years. You lose the experience that patients may want to have when there's something nice about seeing that senior physician. The wise preceptors, the wise educators. Patients may have the comfort from having that seasoned provider who's seen it all and can reassure them. The lifetime experience, having seen those unique cases before. There's an uncertain impact on patient safety if there was mandated retirement. You might remove some folks from the workforce who had a decline in cognition that was putting them at risk to harm folks, but we'd also lose a lot of really competent folks. We would lose leadership. One of the challenges of doing this process is that lots of the folks that I end up testing or that our staff end up testing are folks that are the chiefs of departments. So we had to look at current trends. There's no national standard for what organizations should be doing. We can look at what some hospitals have done. So Stanford Hospital and Clinics, Lucille Packard Children's Hospital, they do physical and cognitive screening at age 74 and a half. Intermountain, they do physical and cognitive screening at 72. The University of VA Medical Center in Charlottesville and Los Robles Hospital and Medical Center, they did cognitive screening at 70. And Yale in 2018 started screening cognition for those 70 plus. So there wasn't really any, when we were looking at this, or I guess I wasn't looking at this right away, I shouldn't say we, but our staff, our wellness committees, our medical executive leadership were looking at this issue in 2017 and 2018. And when there isn't great data on what is the standard of practice, what you do is you create your own standard. And so this is what happened at HHC. We created our own standard based on the data, the literature, the best evidence. And there's been a cycle of, there's been revisions. We've been working on this, and we just published this a couple months ago, looking at what our process is and kind of getting it out there to the world so that other folks can use this to help inform what they're doing. So the goals of the new policy, they align with HHC core values: protect patients and their families, ensure delivery of the safest and highest quality care, and protect providers. It's that simple. So we want to protect people, make sure they're getting good care, and protect our providers. The critical application issues for this is that we want to respect your provider dignity, reputation, and legacy. And you know, this process is scary for anyone. Being told we're going to be testing your cognition is scary, even for the most competent folks out there. The scope of the project for Hartford Healthcare. So I know this is IOL, but you know, we have 7 acute care hospitals and large BHN, a large multi-specialty group. There's over 30,000 employees and 3,000 employed or affiliated physicians. Across the last few years of this project, we've always had about 100 providers who are 70 plus across the system. We had 3 objectives, like I said: protecting patients and their families, ensuring the delivery of the safest quality of care, and protecting the providers. The Health and Wellness Committee represents all of our hospitals. They reviewed data, they reviewed best practices. And then as they went through this, all hospital medical executive committees, board of directors, regional boards, and quality and safety committees were involved, and they eventually all voted in favor of this process. They decided that physical and neuropsych screening would happen annually after age 70 as part of re-credentialing, and that was approved by all the boards and MECs. There's a change management part. So medical staff, and so in order to do this, and this is just the leadership part that I certainly was not part of, but it was fascinating to look at. Medical staff and department meetings occurred for months. They recommended the approach. It was approved by all these officers and VPMAs and the board of directors. The medical staff meetings, they had large forums. They were positive, but certainly not unanimous. Folks who were over 70 and were physicians were active advocates for this process with their peers, which helps. And then the why has to be explained. And, when you hear this, like I mentioned before, folks feel that this is a process that's really mandating retirement, and that is the exact opposite of the goal. The objective is to protect patients and to protect providers, their career, their reputation, their legacy, and their livelihood. And I think that is just a critical thing to continue to understand, is that the goal is to protect folks. Mandated retirement is not the goal. There's lots of considerations, and I'm just going to mention some of these, and then if we want to talk about that in the Q&A time, we can. Who is the client and the patient, and when does this change? So I view this as kind of an IME. This seemed to me we do not We are not establishing a patient-doctor relationship. There's no confidentiality in these evals. Really, the providers are not giving their consent. They're assenting to the process because it's part of getting recredentialed. There's, psychology's APA says that we have to avoid harmful multiple relationships. I know some of the providers that we're seeing. I interface with them. So do our staff. And so we had to have thoughts about that. And again, I could talk about these things if you want to later on. There's an added burden on providers and on the folks who are assessing them by having them come over to IOL to do these evals. There's stigma. In those large meetings with the wellness and the medical staff, providers widely indicated that cognitive change is something that's personal and negative and that they're not comfortable with, whereas almost no one disagreed that if you have a physical change, it would make sense to have a change in your employment status or your credentialing. There's the CT Public Act 15.5, Section 480, where there's mandated reporting of impaired practitioners. So we must report any information that appears to show that a healthcare professional is or may be unable to practice with reasonable skill or safety due to aging, mental illness, substance abuse, or neglect. So there's just a lot of different considerations to think about in a process like this. Next section, what's the right way to assess? I'm biased. So really quickly, physicians are really highly educated. Most screens lack sensitivity due to their cognitive reserve. Physicians are different from other highly educated groups. So normal scores for a physician are actually higher than similarly educated individuals. High education norms may not be useful for all physicians. Our process doesn't just include physicians, and we get really unique, challenging people to figure out what actually is the decline for them. We have folks who have doctorates in areas that are not medicine and are not psychology and are and it can be really confusing to figure out what norms should we compare them to? What's the reference group? The pilot data is interesting, but it's really a different skill set to be successful there. And it's important to think about what your thresholds are, because we know that older surgeons who, when you test them cognitively, perform like their younger colleagues, they have a similarly low morbidity rate. But as I mentioned earlier, those surgeons who have cognitive decline, they have much higher morbidity rates. Real quickly, as folks know, the bell curve, if you dump a bucket of sand upside down, most of the sand falls in the middle, less out on the extremes. In the general population, we expect most folks to fall in the middle in all the domains of cognition. If we're betting, we expect folks to fall here. When you look at physicians, we expect them to try hard on our testing, and we expect their cognition. The average physician IQ is about a 125. No one's really looked at that in about 30 or 40 years, but the data that are there, they've always hovered in the 120s. That makes sense. And you expect their other areas of cognition to roughly hang with IQ. You can have some scatter, and that's what I'm trying to represent with this really beautiful Microsoft Paint diagram, is that when folks are in this high average range, a little scatter doesn't bother us. When folks start dipping down into the average range on some of our tests, especially if it's multiple tests of the same domain, that begins to give us a concern. And then when you get into like the low average range or borderline or the impaired range, you really have to start thinking like, wow, there's likely a big change here and it's going to impact their practice. There's lots of different approaches you can use to screening physicians. We used a microcog. It's computerized. It was just created by risk management from Harvard Medical Institutions. Sorry about that blip. I don't know what's going on. It has 18 subtests with 9 summary scores. It has an easy interface. So there's been studies that show if you can use an electronic health record, you can do it. There is different cut scores, but there's physician appropriate cut scores in the literature. That's what we use. You can't use general population norms because it would under-identify impaired physicians because they are so smart. And as our process evolved, we changed our cut scores. We made them a little more stringent. And by doing so, we actually didn't increase. We had no increase in false positives, but we did capture some folks that we did a fuller eval on that we wouldn't have captured initially. So it increased. We have not had a false positive. If physicians pass the screen, they were told that their reappointment would continue normally. So if you pass this 45-minute or hour-long microcog, you're good to go until next year. If there was a finding, we asked you to come back for a comprehensive evaluation. Physicians also have a physical eval. I'm not going to go into this in great depth because I'm looking at the time, but it's basically the geriatrician will do a bedside neurological and ask some questions about their functioning their health functioning, burnout, mood, etc. There's other approaches in the literature. There's other computerized assessments. Some folks will use more traditional, longer neuropsych batteries that are brief, but they're still a bit longer. For the neuropsych folks, you know what these tests are. It's IQ, it's reading that's used to estimate premorbid intelligence, a memory test, a test of reasoning, and then a general cognitive screen. Yale hasn't published their battery, but it's a 1 to 2 hour evaluation. They detect a decline in about 13% of their providers who they evaluate with it, and they do it every year. I think it's every year. Perry and Crean, 2005, looked at, this is the PACE program at UCSD. It's this really great program where physicians are referred for questions of competency and fitness for duty. They found that referred physicians, folks that there was a concern about, their IQ is usually in the average range. And sometimes they have some scores that are lower. And again, remember, that's actually a decline for physicians. We expect them to be higher than the average range. Generally, there's always wobble or, a scatter within any given individual. There's some tests, like those looking at verbal learning, speed and executive functioning, and attention, that had discriminant validity in their sample, where they were able to say these folks on these measures, when they're referred for competency, look different than physicians who are not referred for competency. And there were several domains that show impairment from the estimated IQ of 125. Again, so assuming a degree of scatter is normal, but only so much scatter is normal between your memory, for example, and your overall IQ. 60% of their providers who were referred for a neuropsych had 3 scores at least a standard deviation below the norm. In practice, the microcog has been used to look at controls and folks evaluated for competency. You can see the mean scores for those evaluated for competency were significantly different with, reasonable effect sizes. And so it's been a useful test in the literature when you use these index scores to differentiate those physicians who have were referred for competency versus controls, suggesting that when we use it as a general screen, if you're similar to this group, we might want to do more assessment with you. Again, this is a distribution of scores. The light gray is the control group. The dark gray is the competency group. And just to show you graphically, folks who were referred for the eval in the microcog tend to score lower. The distributions do overlap, but there's a clear differentiation between the two groups. So for our battery, we wanted to look at estimating your baseline intelligence besides looking at folks just knowing their background. We also wanted to look at it psychometrically. We do a lengthy intelligence test. We test all domains of cognition, so attention, processing speed, executive functioning, visual spatial functioning and construction, language functioning, learning and memory, motor functioning. And for motor functioning, we don't just compare you to your same age. We also compare you to folks who are in their 50s, because, again, if you're holding a scalpel, it doesn't matter how old you are. It matters how well you can hold it and wield it. And then we look at measures of depression and anxiety as well. We would normally do, as for folks who know us in psych testing, we would normally do a larger battery looking at mood or personality, but the medical staff in negotiations, they decided we did not want to do that whole eval. This is our outcome from our first 2 years. So of the 30,000 employees, about 3,000 were in the over 70 age group. Of them, we tested 160. 30 individuals were tested both years. Of them, about 26% changed status to community affiliate or retired before we assessed them. So we only had to test 118 total patients. Of those, all but 20 passed the microcog and their reappointment continued. 19 were below our cut on the microcog, and 1 had a computer error. You know those little fire warnings that come up and your computer's going to restart? Like, it was one of those issues. We couldn't stop it. My poor postdoc was trying to stop it and couldn't, and so we had to, based on the data we had, we did a full eval, but that provider passed the full eval. Of the folks in the first couple of years who were identified as having concerns on the microcog, 2 changed status to community affiliate, which is a way not to complete the whole process. Our process targets those who admit to the hospital, and so a community affiliate doesn't have admitting privileges, and so and isn't involved in hospital work, so they were then removed from the process. 17 completed the full eval. 2 of those who did the full eval had mild findings, not yet consistent with mild cognitive impairment. Both of them changed status. And these were folks who were really, really bright at baseline and had just a few more scores in that average range than you would expect. It didn't look like normal variability based on their careers and their history. And so it suggested there may have been some changes. It probably didn't impact their work, but they both opted to change their status. 13 met DSM-5 criteria for mild cognitive impairment. And then there were these 2 others. There was 7 total in this group of 15 that English was not their first language. Of them, 2 of them had findings that were only related to language tests. And so we didn't know what that means. When English isn't your first language, we don't have great tests in every language from folks from every background, especially physicians in every background. So in that case, they were reappointed with an exam in 1 year to monitor for change. The other 5 looked like they had MCI because their deficits were not in language-based domains. And then of these folks, only 1 person has retired who was flagged by this process. Everyone else has continued working with modifications or while undergoing a focused professional practice evaluation, which varies depending on specialty and the context of the findings that we have. So for those who have findings, we make safety recommendations. For some folks, it might mean reducing or ceasing their procedures, spending more time with patient, having someone else accompany them with some patients, using memory aids or having a scribe, having peer consultation, oversight, or overview. So usually the FPPE involves someone looking at notes and joining them in clinic for a period of time. There may be second opinions sought for some patients or for some of their patients if they're more complicated, and we encourage them to use that as a resource. Some folks may shift to doing more teaching than intervening because there's inherently less risk in that. They may move to senior scheduling and have less hours, and folks actually, they get rid of their call, and they often don't complain about that. The outcomes are never identical, and this is a really important point. The outcome, like I have pointed out, we only had 1 person retire because of this process or after this process. It's not mandated retirement. But we can have 2 folks, we've had this happen, where 2 people from the same department who have already changed their practice in very different ways. 1 person is still functioning like they did 30 years ago, taking 60 or 80 hours of work. Another person has already kind of reduced their responsibilities, reduced their call, is doing less procedures. For those 2 people with the same sorts of test findings, obviously the implications are different. The person who's reduced what they're doing already has made a lot of the accommodations that we would recommend, and there might not be a great change for them. The person who's still kind of going full out, we may recommend more changes for them. We have conversations. We offer all the providers who've gone through this process, about an hour feedback session. And depending on the findings, we really want to talk about that. As I mentioned, being a physician is who a lot of people are. It's a huge part of their identity. And, it's worth thinking about. Where are you going to find value in life after medicine? Is it more time with your family? Is it traveling? Is it writing? Is it mentoring others? Are there other ways to leave a legacy? Because everyone at some point is going to retire. Everyone at some point is going to work less. And it's important that you don't just leave a void. And for some folks, they haven't considered that. And it's not necessarily even related to cognitive change. This is who I am. But it's worth having that conversation. So again, our policy is not mandated retirement. The vast majority of those who are screened pass. Those with findings, the vast majority continue to work. I thought this was interesting data. In the 2 years before our program started, so from 2016 to 2018, 50% of providers in that group, age 70 up, retired or relinquished their privileges. And in the first 2 years of our program, 26% retired or relinquished before we had testing, and only 1 after testing. So it really did not look like our testing led to any increase in retirement or relinquishing privileges. There are complexities with this, and I'm gonna stop in 4 minutes so that if folks want to talk about any of these or have other questions, we can do that. And so just here are some of them. So one is resistance. So there was resistance to the program generally, and that might mean that when we ask them to call, or when the MSO asks folks to call in and schedule, they just don't call or don't schedule. There are folks who, when we give findings, I've had the opportunity to defend neuropsychology as a field with some of our providers, and to defend a person who's not an MD or DO assessing someone who is. There's been a lot of challenges and pushback at times into the entire science of neuropsychology. And it's reasonable. It's really reasonable. There are providers who've come back and said, I remember the entire list you read me, and they listed it off for us. They email it to us. And they may have really good memory. We have had folks point out that they have wisdom, and that's true. But anyway, so there's resistance to the findings. One of the nice things that we've had, and I'll just highlight a couple solutions, is we've had some providers that we met with multiple times after they had findings, and eventually one of the persons who pushed back the hardest ended up asking me for a copy of the report to bring to their physician so that they could follow up with some recommendations that we had. So I considered that a win. We have some difficult situations. As I said, it is upsetting to have to do this. People feel judged. They feel like their livelihood is in danger. They are anxious, and we really try to minimize that as much as possible. We try to talk to folks in advance if they are concerned. We try to really give them a frame for the assessment. If they have a finding, we try to talk to them about the meaning before we schedule them. When they come back for the full eval, we try to talk about what this is going to look like. But no matter what, there is discomfort associated with this. Some folks, I wrote validity modifying behaviors. So we've had, we always have someone proctoring the computer screening, and we've had docs, they see that they have to memorize, there's a memory test coming out, and they take out their notepad and start writing down the stuff we're asking them to memorize. We've also had folks take out calculators on their phone when we ask them to do like mental math or something like that. I don't think those folks were intentionally trying to cheat, but they say, oh, I'm sorry, I'm just used to taking notes on this stuff. We have had issues where there's some behavioral discontrol from the providers, a really emotional reaction that's challenging, and we've tried to work with that. We've had some folks, call up and had some unfriendly words for us, and we deal with that with leadership behaviors. The functioning as a team has been a really cool part of this, and so having all these different disciplines and these different aspects of HHC leadership, legal, the chiefs, the VPMAs all work together, and having neuropsych as part of this team and having Gero as part of the team has been a process that we keep growing in. We all have to respect. So I don't know it's my job often to describe what the cognitive deficit is, and then the chief will explain what this person is actually doing day to day. And then we work together to figure out what that might mean and what an FPPE might look like for that individual, what the plan is going to be for that individual based on that. Part of that is speculative too, though. And so we really have to have a thoughtful conversation. And then the head of the medical staff comes to these meetings kind of as a representative for the staff themselves to represent their interests. And finally, the legal and ethical issues. So some folks want clinical feedback, some folks want a diagnostic impression, and some folks don't. And really, when you think about it, from a hospital standpoint, a diagnosis doesn't matter. What matters is your current level of cognitive functioning. And so it's perfectly justified for a provider to say, I don't want you to share a clinical impression with me. Okay. There are legal considerations with this. Oh, but if they don't want me to share sometimes they'll say, don't put it in the report, but share it with me personally because I want to know what I should do. And I want advice. I just don't want anyone else to know. I feel like it might leak. Very valid concern. The legal considerations I mentioned earlier, and then roles and conflicts of interest. So as I mentioned, a lot of our chiefs, a lot of our most senior and well-respected providers are in this age group. And so, there's inherent conflicts of interest if we're evaluating folks that we know, who we report to, or anything like that. And we do our best to mitigate those concerns. I can talk about how we do that if that's of interest to people too. So I'll stop there, a minute over, and take any questions that folks have, and I'll leave the activity sign-in code available. And so if there are any questions, you can type them in, or let me see. I'll scan up and see if anything's sitting there. Oh, we wanted the CME code. Oh, so I'm just scanning up and I'll answer questions that are here for those interested. So Dr. Naveed asked, what about acquisition of new clinical knowledge? Does it get impacted? Yes, absolutely. So if you have cognitive change over time, learning can slow down. And so for folks who are in like the pathological, folks who have a identifiable change in cognition, they are going to may have more difficulty acquiring new skills, new clinical knowledge. For folks who have normal aging, perhaps or perhaps not. It really depends on the specific circumstance. And I'm not sure if that answers your question adequately, but it's going to be a nuanced answer. Okay, I don't see any other questions in the chat. So if anyone has a question, please feel free to ask. Oh, Evan. So Evan asked about false negatives and false positives and how we address that. That's a great point. So it's hard. So we have to balance one of the things we have to balance is we're balancing dignity, we're balancing burden on providers, and we're balancing the legal implications of doing this work. And really, the goal is to reduce. One of the goals is to reduce liability, not to increase it. So we've increased our threshold and our cut scores. By doing so, we have not had an increase in false positives, but we have no idea. And by false positives, I mean we have identified at least some kind of cognitive change on everyone who's identified by the screen when we do the full eval. It's very possible that we have false negatives, and that's a real challenge. I think one way around false negatives is that if someone, it's to screen regularly or to have, repeated screens, not to do this as a one-time thing. Another, there are other processes in place, like the normal evaluation process that folks go through at credentialing that should identify folks who have changes in their functioning. And so that's another way to look at false negatives. I guess then the other answer to that is the medical staff fund. We're looking into getting funding, and it sounds like it looks very possible to developing local norms. So, and I don't know if we're going to get physicians or providers to do this, but to test folks in their, mid-career, develop some local norms, make sure that we're using adequate cut scores, and see if we should be changing those. And that'll be something that'll be neat to come out of HHC, but local norms will be important. I think one of the biggest risks for the false positives, false negatives, or errors are these folks who are non-native English speakers, learned English in their, in their 30s or 20s, and it's really hard to figure out at times what is a change. And so during that year before their follow-up eval, they'll often have some sort of monitoring for a period of time that hopefully would help if we have a false negative. Dr. Schwartz asked, what about reporting requirements? Why are you not obligated to report folks who you think may have an impairment affecting practice? I would love to turn that over to Jackie Hurl to answer. I think it's a great question. And so oftentimes when we've done these assessments, the conversation that occurs between myself and the DPMA and the chief is, what is this person doing? What is the extent of the impairment that we see, and what is the extent of any functional or changes that have been noted on the job? And the guidance. I'm not the legal scholar, so I can't speak to this as eloquently as perhaps Jackie could. But in most cases, it has been the case where they have seen, we have evidence of some sort of subtle decline. We're going to do the normal FPPE, and the thought is that the cognitive change has not met, because we have we're testing really thoroughly and with redundant tests, that folks appear to have a change that is not at that level where we think it would have an impairment, a clear impairment affecting the practice that they're engaged in. They're also limiting the practice, and I don't know what that does legally. I can't answer that question. I apologize, Dr. Schwartz. But it is a really good question. If we had a provider, theoretically, who had really significant impairment, like look like they had dementia, or a really obvious dementia, would probably bring up a mandated reporting concern. And I imagine that would then be a different conversation. I'm not aware of that having happened. So this is a great question. Dr. Weiss was asking if we are going to roll this out to community providers or community hospitals. I have talked to folks in administration about offering this as a service. I think we could become like a regional leader. We have lots of folks who are good at this, and we have a nice process in place. We have done some evals for other hospitals. It's really in a nascent state. But yeah, I think it would be a really neat thing for us to do. And, we would feel good about it, offering this service for the region. David, I don't know if that's David Pepper or someone else, Dr. Pepper. I don't know of research on psychiatrist capacity. And it's a really good question. If we test a psychiatrist and what markers would you be using to judge functional impairment is the question. Functional impairment, I would be concerned that if we see someone who has changes in memory, let's look at documentation. And perhaps even if you have someone, like we do during training, if you have someone observing sessions, you could observe. You could see if the documentation matches. You could see if the prescriptions or the interventions, the psychosocial interventions, make sense. It would probably be something like that to look for functional impairment. I guess you could use vignettes if you wanted to, but again, I don't know of anything where that's happening right now, and I'm just kind of spitballing an answer to the question. But we certainly, if we tested someone and we saw a change in those key aspects of psychiatry, which to me is judgment, language functioning, communication, memory. If we saw changes there, we'd be concerned, and we would ask the FPPE to really be evaluating, again, whether notes make sense, whether there's patient complaints about perhaps memory issues or confusion, things like that. Dr. Pendergrass. No. So Dr. Pendergrass asked if we've had many or any people self-refer. And so, no, we have not had anyone self-refer. This is a mandated process at age 70. We also, going back to that earlier question of, that Dr. Weiss asked, could we offer this as a service to the region or even locally? Like, I would love it if our neuropsych service was involved when there's concerns with functioning in folks at a younger age. That would be really neat. I think we could offer something there. There are these ethical issues, again, because we're working in this institution, and perhaps, for psychology, there's multiple roles. We have different ways to de-identify data and to try to mitigate that risk. But yeah, we right now we don't have, I don't know of anyone who's ever self-referred for an evaluation. And yes, it would be great if we had a culture of self-awareness and destigmatization of cognitive issues. I agree with you. It's challenging, and as I mentioned earlier, cognitive change. I think cognition is just such a core part of what people value about about who they are. That there's something different in that than having a physical change. It really strikes to the core of who a human is. Dr. Pendergrass also asked about the number of physicians who become community affiliates during this process. Yeah, it's a great question. I wanted to know if folks are avoiding testing possibly. I would guess, I would have to ask the CVO and the MSO those questions. I don't know the answer off the top of my head, but the rates weren't all that different, and actually were less during the years that we started this program versus the years before it. But I'm sure there are some people who change affiliation to avoid testing. Now, the people who do that are the folks who, were probably coming in and seeing one case a year in the hospital. But yeah, you're absolutely right. Until there's national standards, until there's an expectation for this process to occur for all providers, there's going to be ways to avoid the testing by not being part of an institution that's doing it. Dr. Blank asked a question about enough experience with female physicians to be able to comment on gender differences, especially regarding self-monitoring and insight. That's a great question. I guess we're probably up to 30 physicians now who've had findings, and so this is anecdotal, Dr. Blank. I don't have a specific, I don't have data on this, but I haven't seen any differences in self-monitoring or insight in the groups. I think it's been a pretty even dispersion of folks who've asked for more follow-up questions, have really tried to learn more about their cognitive profile and tried to figure out what can they do, what's the best in their best interest, in their patient's best interest, and folks who have kind of like really pushed back hard. So I don't know that I've seen a gender difference there. I think one of the gender differences I have seen is that in our late career group, the physicians have been, I think there's been more male physicians and we've had more female APRNs, but that's probably not a surprise. I think it's fairly consistent with the general workforce. If anyone else has a question, there's 3 minutes. Some of you are kind enough to hang on. Okay. Erica, is this an okay time to sign off? Unless you're gone.
Kevin, it's Rob. If you want, yeah, you can sign off now. I'm going to disconnect everyone.
Okay. Thank you all for your time. I enjoyed talking to the group, and if anyone wants to follow up, you can email or contact me. Kevin Young over at Psych Testing. Thanks again.